If you are a woman going through perimenopause or menopause, and you're experiencing what feels like, well, chronic agonizing thrush, the medical data actually says there is upwards of a 93% chance that you do not have thrush at all.
Which is just, I mean, it's a wild statistic to actually wrap your head around.
It's completely wild. You are essentially treating a ghost. And if you've been caught in this awful loop of, buying over-the-counter yeast infection creams only to end up right back at the doctor's office with another urinary tract infection just a month later, you are entirely not alone.
No, not at all. It's incredibly common.
So welcome to this deep dive. Today, we are opening up clinical guidelines from the American Urological Association, data from the British Menopause Society, the British Association for Sexual Health and HIV, and some really revealing clinical case studies.
Yeah, we've got a really solid stack of sources today.
We really do. And our mission here is to answer a highly specific, highly frustrating question for you, which is, why am I getting recurrent UTIs and what feels exactly like thrush during menopause?
And to really answer that, we have to look completely beyond the surface level symptoms. We need to investigate the underlying environment.
Right, the root cause.
Exactly.
Yeah.
We are looking at how the natural drop in estrogen just completely rewires your internal defense system. Specifically, we're talking about the largely invisible ecosystem of your vaginal microbiome. And honestly, the tragedy here is the sheer scale of the medical gaslighting surrounding this physiological shift.
Oh, absolutely. I mean, looking at the statistics from the British Menopause Society data, it is genuinely staggering. They found that up to 87% of postmenopausal women experience symptoms of genitourinary syndrome of menopause, or GSM.
87%. That is almost everyone.
Right. But here's the kicker. Out of that 87%, only about 7% actually receive treatment.
It's awful.
It really is. For millions of women, the burning, the itching, the painful sex, the frequent bladder infections, they're completely brushed off by doctors and, sometimes even by the women themselves. It's just a normal part of getting older.
Yeah, it's a massive systemic failure in our standard care models. Women are repeatedly handed these, quick fixes for isolated complaints, while the actual root cause just goes entirely ignored.
Which brings us to the first part of our mission today. We need to unpack the first half of your question, which is the recurrent thrush.
Right. So the medical term for thrush is vulvovaginal candidiasis. And the data clearly shows that true yeast infections are incredibly rare in postmenopausal women.
Which I have to say feels completely counterintuitive because the symptoms women describe, the burning, the itching, they're identical to a severe yeast infection.
They really are. But the biological mechanism behind why true thrush is so rare comes down to, well, cellular food supply.
Okay, break that down for us.
So Candida, which is the specific yeast responsible for true thrush, is highly dependent on a very specific environment to survive. It literally thrives in a high estrogen environment.
Because the estrogen is feeding it.
Kind of, yeah. Estrogen prompts the epithelial cells that line the vaginal walls to produce and store a type of sugar called glycogen.
Okay, so glycogen is the sugar.
Right. And as those cells naturally shed over time, they release that glycogen into the vagina, which basically serves as an all-you-can-eat buffet for the yeast.
Ah, I see. So as estrogen levels naturally plummet during menopause, the glycogen production in the tissue just plummets right along with it.
Exactly. The food source vanishes, the yeast is effectively starved out, and because of this, the actual prevalence of true thrush in postmenopausal women drops to just 3 to 7%.
Wow.
And it decreases even further every single year after age 57.
Okay, wait, I have to push back here for a second. If the yeast is starved of glycogen and is effectively dead, that 3 to 7% prevalence rate still feels artificially low to me based on what women are reporting.
How do you mean?
Well, I mean, women aren't imagining the burning, right? They aren't imagining the pain or the micro tears in the tissue, and they definitely aren't imagining the genuine relief they get from those over-the-counter thrush creams.
That's a really good point.
So how are the clinical guidelines actually reconciling that massive gap between the data saying no yeast and the lived experience of the patient saying it burns?
Yeah, so the clinical guidelines reconcile it by making a really crucial distinction between an active fungal infection and severe tissue degradation. What women are actually experiencing in the vast majority of these cases is the vaginal atrophy and dryness component of GSM.
Genitourinary syndrome of menopause.
Right. Without estrogen, the vaginal mucosa physically thins out, it loses its elasticity, the blood flow decreases significantly, and the tissue becomes incredibly dry, fragile, and just super prone to microtrauma.
Ouch.
Yeah. And that mimics the burning and itching of a yeast infection perfectly because the nerve endings are literally inflamed and exposed.
Okay, but what about the creams? Why do they work if there's no yeast?
Ah, so the over-the-counter creams are just acting as a soothing emollient.
Oh, because they're basically just a thick lotion.
Exactly. They're formulated in a highly moisturizing, thick cream base. When you apply that to dry, inflamed, thinning tissue, of course it calms the irritation. You get a soothing effect. But the active antifungal ingredient in the cream isn't actually doing anything.
Because there's no fungus to kill.
Precisely. It masks the root cause of the tissue breakdown.
That is wild. So you're basically just moisturizing a wound.
Pretty much, yeah. And there's another huge piece to this puzzle. Since the estrogen loss is starving out the yeast, it is also suffocating the primary defensive layer of your microbiome.
Okay, now we are getting into the really invisible stuff. We are talking about the good bacteria, right?
Yes, specifically a genus of bacteria called lactobacillus. In a healthy reproductive age vaginal microbiome, lactobacillus species make up over 90% of the entire ecosystem.
90%.
Yeah, they are the absolute dominant force down there.
So reading the sources, I kind of came up with an analogy for this. Think of lactobacillus as the ultimate nightclub bouncer.
I love that analogy.
Right. So as long as the bouncer is well fed, they stand at the door and keep the VIP area, which is your urogenital tract, completely safe from dodgy characters and opportunistic pathogens.
They keep the bad guys out.
But your bouncer is strictly paid in one currency, glycogen. And as we just established, glycogen relies entirely on estrogen.
So when menopause hits and estrogen drops, the vaginal walls stop producing that vital glycogen. The lactobacillus bouncers basically starve and die off.
The bouncers leave the building.
They do, and this causes a really dangerous chemical shift. Because lactobacillus bacteria don't just eat the glycogen, they actually metabolize and ferment it into lactic acid.
Ah, lactic acid.
Right. And that lactic acid is what maintains the vaginal pH at a highly acidic, highly defensive level of about 3.5 to 4.5.
So it's essentially an acid shield.
That's exactly what it is.
Yeah.
And without the lactobacillus producing that acid, your vaginal pH naturally rises. It shifts from being highly acidic to being alkaline, usually creeping up above a pH of 5.
And an alkaline environment is basically an open invitation for bad bacteria.
The doors are wide open. All those opportunistic bacteria in the urological guidelines specifically point out bad actors like Gardnerella, Prevotella, and especially gut bacteria like E. coli.
E. coli, which causes UTIs.
Exactly. They exploit that alkaline shift. They set up camp because the acid shield that used to neutralize them is just gone.
Wow.
And the resulting dysbiosis causes this chronic low-grade inflammation, which perfectly explains the unusual discharge and that persistent lingering irritation you've been having.
Okay, so that totally explains the vaginal irritation and the fake thrush feeling. But since this completely alters the vaginal environment, we need to look at how a change in the vaginal pH suddenly triggers a recurrent problem up in the urinary tract.
Right, because they seem like two different systems, but they aren't. Estrogen receptors are not isolated just to the vagina. They share embryological origins, and they are highly abundant throughout the entire urogenital tract.
So they're everywhere down there.
Everywhere. They are deeply embedded in the urethra, the bladder trigone, and even the structural muscles of the pelvic floor. And they all rely on continuous estrogen signaling to maintain their structural integrity and cellular turnover.
Looking at the urological guidelines we have here, the advanced biomechanics of what happens next are just crucial to understand. So without estrogen, the urethra actually physically thins out.
It shrinks, basically.
Yeah, the tissue loses its vascularity and its structural plumpness. And because of this degradation, the urethra can actually avert and prolapse.
Which means the delicate intermucosal lining gets exposed outward.
Exactly. So you have a shortened, compromised urethra combined with the complete loss of your acidic lactobacillus bouncer at the vaginal opening.
It's a perfect storm. This physical vulnerability creates a direct, undefended route for pathogenic bacteria, particularly E. coli from the gastrointestinal tract, to travel straight up the urethra and colonize the urinary tract.
And that is how the UTI happens.
Yeah.
Let's actually look at a specific patient journey documented in these urological case reports, because I think this beautifully illustrates what they call the terrain problem and the exact point where standard medical care just fails so many women.
Yeah, the case studies were really eye-opening.
So we have a 54-year-old woman. She's 5 years post-menopause. She starts experiencing agonizing, frequent UTIs. She goes to an urgent care clinic, provides a urine sample, and complains of severe bladder pain, urgency, and vaginal burning.
And the standard knee-jerk medical reflex in that specific scenario is to immediately prescribe a 5-day course of systemic oral antibiotics,
Hmm.
like nitrofurantoin or ciprofloxacin.
Right. And often they prescribe this before the urine culture even comes back from the lab.
Oh, almost always.
And when the culture does eventually come back, it often reads something like mixed flora or suggests contamination, which confuses the doctor, but the patient takes the antibiotics anyway.
Because they just want the pain to stop.
Exactly. And the antibiotics do go in and kill the immediate E. coli flare-up in the bladder. She feels better for a couple of weeks. But systemic antibiotics in this scenario act like setting fire to a forest just to kill a few weeds.
That's a great way to put it.
You eliminate the immediate bacterial threat, but you leave behind this charred, undefended soil.
Right. Because the antibiotics wipe out whatever tiny, struggling population of good lactobacillus you might have had left in the vaginal and urinary tract. They leave your internal terrain completely barren and highly alkaline.
Which means the root cause hasn't been fixed at all.
Not even a little bit. The estrogen deficiency, the cellular atrophy, the lack of glycogen, and the high pH, none of that has been addressed.
So because the environment is still alkaline and physically compromised, the bad bacteria just migrate right back over from the gut.
Yep. And because there is zero competition from good bacteria now, those pathogens return faster and stronger than before.
So the 54-year-old patient gets another UTI 6 weeks later. She goes back, she gets another round of antibiotics. This time, maybe they give her a stronger one.
And now she has gastrointestinal distress from the new antibiotics, and her vaginal burning is worse than ever.
It's a nightmare. It leads to this worsening cycle of dysbiosis, escalating tissue damage, and immense psychological frustration for the patient. She begins to feel like her body is permanently broken.
Trapped in the postmenopausal UTI cycle.
Exactly. But since systemic antibiotics are actively racening this alkaline trap, we have to look at the interventions that actually restore the acid shield and rebuild the mucosa.
The solutions.
Right. And the good news is the clinical consensus across all these governing bodies points to one highly specific, localized treatment.
Yes, the absolute gold standard for treating this root cause, endorsed by both the British Menopause Society and the American Urological Association, is local low-dose vaginal estrogen.
And then just to be clear, this is not a pill you swallow.
No. It comes in the form of creams, localized rings, tiny dissolvable tablets, or pessaries that you insert directly into the vagina.
The biomechanics of how this localized treatment works are so fascinating to me. By applying the estrogen directly to the tissue that is starving for it, you initiate cellular repair precisely where it's needed most.
It's totally targeted.
Yeah. You reverse the mucosal atrophy, you visibly thicken the vaginal and urethral walls back up, which restores their structural integrity and resolves that urethral version we talked about.
Furthermore, that local estrogen signals the epithelial cells to finally resume producing and storing glycogen.
The food is back.
The food is back. That restored glycogen supply acts as a beacon, bringing back the lactobacillus. And as the lactobacillus colonizes and ferments the new glycogen, they drop the vaginal pH back down to a highly acidic defensive level.
You are quite literally rebuilding the fortress walls and reinstating the bouncers at the door.
That's exactly it. And the clinical data notes that effectively doing this cuts UTI recurrences by 50 to 60%.
That is a profound risk reduction for such a highly debilitating issue. However, I think it is perfectly natural for a listener to hear the word estrogen and immediately feel a spike of anxiety regarding safety.
Oh, absolutely.
Because, there are all these historical fears around systemic hormone replacement therapy or HRT and the risks like breast cancer or blood clots.
It is a vital distinction to make here. Local vaginal estrogen is fundamentally different from systemic oral HRT.
How so?
Well, because it is applied locally at an extremely low, almost microscopic dose, it remains in the urogenital tissue. Only clinically insignificant trace amounts ever enter the systemic bloodstream.
So it's not floating around your whole body.
Right. It does not carry the same risks as systemic HRT. It is considered incredibly safe for long-term continuous use.
In fact, the guidelines point out that it is so targeted and localized that even women who are strictly advised against taking systemic HRT, like due to an estrogen receptor-positive breast cancer history, are often safely cleared to use local vaginal estrogen by their oncologist just to manage their severe GSM symptoms.
Yes, the safety profile is excellent. And the clinical reports also highlight a frequent point of confusion for patients. Even women who are currently utilizing systemic HRT, like maybe they wear an estrogen patch, or take a pill for systemic symptoms like hot flashes and bone density protection, those women often still require local vaginal estrogen at the same time.
Wait, really? The patch isn't enough.
Often, no. The systemic dose you take for your brain and bones just isn't enough to reach and repair those highly specific, estrogen-demanding urogenital tissues.
The vagina and urethra are incredibly greedy for estrogen.
They are very demanding, and they often demand direct, local application to fully resolve the atrophy and restore that acid shield.
Okay, so local estrogen is the gold standard, but the clinical data also highlights several other evidence-based strategies for rebuilding your urogenital terrain, right?
Yes, there are a few other tools. One significant intervention is vaginal DHEA, which is also known generically as prasterone.
Ah, right. And DHEA operates through this fascinating mechanism called intracrinology.
Right, it's really cool.
It is. It is a daily vaginal insert that contains a precursor hormone. So your vaginal cells take that precursor and they convert it locally, inside the cell, into both active estrogen and active testosterone.
Which provides really targeted relief for pain, dryness, and tissue atrophy without raising systemic hormone levels in the blood. So it offers an alternative pathway to tissue regeneration.
What about probiotics?
So there's also a rapidly growing body of clinical evidence supporting specific targeted probiotics to help aggressively reseed the environment while the estrogen rebuilds the cellular architecture.
But we should clarify this is not about grabbing a generic digestive probiotic off the grocery store shelf.
No, absolutely not. Gut probiotics won't do much here. You need highly specific bacterial strains clinically proven to survive the journey, adhere to vaginal epithelial cells, and actively produce lactic acid.
And the urological data specifically name strains like Lactobacillus crispatus and Lactobacillus rhamnosus.
Yes. Taking these specific strains, either orally or via targeted vaginal suppositories, can significantly accelerate the restoration of the acid shield.
Finally, we have to address the lifestyle defense because while you are utilizing these clinical tools to rebuild your terrain, you must protect whatever acid shield you have left by aggressively avoiding severe pH disruptors.
This is so important.
It really is. This means throwing out heavily perfumed body washes or those so-called intimate hygiene products that just completely strip the mucosa.
Stop overwashing. The vagina is self-cleaning.
Right. And skip the tight synthetic clothing and damp workout gear that create a sweaty, alkaline breeding ground for opportunistic pathogens. You want to cultivate an environment that supports your lactobacillus, not one that suffocates it.
Exactly. Synthesizing this entire clinical journey, the reality becomes undeniable. What manifests as endless, painful UTIs during menopause and what feels to you like an incurable recurrent thrush infection is very rarely a simple, isolated pathogen problem.
It is a terrain problem. It is driven by your naturally dropping estrogen, which stops glycogen production, which starves your lactobacillus, which spikes your pH, which ultimately allows gut bacteria to flood your thinning, physically vulnerable urogenital tissues.
And we deeply validate your frustration. If you have been caught in this agonizing loop, sitting in a doctor's office, paying copays, receiving negative or ambiguous urine cultures, and just being handed endless systemic antibiotic prescriptions that actively destroy your remaining defenses, it is because the true root cause, genitourinary syndrome of menopause, has been entirely ignored.
But armed with the data from this deep dive, you don't have to remain trapped in that cycle of medical gaslighting. You can advocate for yourself. You can request interventions like local vaginal estrogen or vaginal DHEA that actually rebuild your mucosal defenses and repair the terrain rather than just repeatedly scorching the earth with antibiotics.
Understanding your own microscopic ecosystem is the essential first step to permanently reclaiming your comfort and your health.
Now, before we wrap up, I want to leave you with one final, deeply provocative concept pulled from the cutting edge of these clinical reports.
Oh, the estrobolome.
Yes, yes. We've spent this entire deep dive detailing how your vaginal bacteria react and die off in response to your changing hormone levels. But recent microbiome research suggests that this relationship is actually highly bidirectional.
It's not a one-way street.
No. We are looking at a concept known as the estrobolome. The idea that the microbiome itself might actually metabolize and modulate hormones locally.
Right, because certain bacteria possess specific enzymes, like beta-glucuronidase, that can actually take inactive circulating estrogen and deconjugate it.
Which essentially turns it back into an active, usable form right there in the tissue.
It's a profound paradigm shift in how we view the human body. Your microscopic bacteria don't just passively sit there waiting for your systemic estrogen levels to dictate their survival. They might actively help shape how those hormones behave, how they are absorbed, and how effectively they are utilized by your vaginal tissue.
It completely changes the entire perspective of treatment. It's a powerful reminder that you are not just a single organism. You are a complex, interconnected ecosystem. And if you invest in taking care of your microbes, providing them the environment and the hormones they need to thrive, they will actively take care of you.
Absolutely.
So the next time you feel that familiar burn, don't just ask how to kill the invader. Ask yourself, what is happening to my terrain?